Some of the interesting data that has already been presented or will be presented at this year's ASH is really potentially quite revolutionary in the fact that there's an update of the master study, and that study is really suggesting if patients get a good response, can we maybe stop their therapy? So at the moment, we're thinking about patients having ongoing maintenance for 2 years, 5 years, 10 years. And what that study has shown is that patients who achieve a good response and have a sustained good response, they're then stopping their treatment and monitoring them. And I think the interesting thing is it's still very early days, but it's looking as if that's certainly a good approach for some patients. So I think that's one way that things are changing. The other thing that I think has been really good at this year's ASH is that there are a number of studies now looking specifically at high-risk patients. And so there's some nice data from both the UK group and from the German group, pulling those patients out and giving them a slightly different approach to therapy. So that's, again, using the monoclonal antibodies, using our PIs, using our IMiDs, with transplantation, with increased maintenance. And those patients, again, seem to be having a much longer progression-free survival. So it's still early days, and many of these studies are not randomized, and that's clearly where the key is going to be. But I think thinking about achieving MRD, thinking about stopping therapy for patients who have an incredibly good response, but then also pulling out subgroups of patients and treating them differently, I think that's where things are beginning to move.